Hello real world clinicians, this is Ali Nasseh with another case-based learning tutorial for you. This is case-based learning number 9. In the past tutorials, we have started by using endosequence, and then we graduated all the way to the Esx basic. I will do one more basic Esx tutorial, and then the following case-based learning modules will be primarily advanced. We'll obviously be mixing them back and forth between basic and advanced, and as I've mentioned before, my goal is for you to all understand how to use this specific system of instrumentation as well as obturation until you are completely satisfied and be comfortable using it in both the basic and advanced cases. So without further ado, let's get started here. The case that I have for you today is again a basic maxillary premolar. This is a second premolar, tooth number 13. As you can see, the tooth is necrotic and it has a large carious lesion in the distal part. There's a periapical radiolucency present as well. And what we decided to do was to do a root canal on this tooth. And we always, as usual, start the case by getting an estimated working length using our digital radiograph. Pre-estimated length on this tooth, it is a 19 millimeter root. And as usual, we start with the same protocol of using a flat disc, diamond disc, to flatten the cusps. And what this does is it allows us to have stable reference points and reduced occlusion. I then use the saber cut, the 1558 SC burr from the Real World Endo Access Kit. And this is a very efficient burr in terms of removing decay, creating an outline form, and giving yourself a very good quick preparation. Once the decay has been removed, now it's time for our final isolation using opal dam or whatever material of choice you have. We cure it in place, so now we have a good isolation. Now I determine the available length, and what available length is you put a number 15 hand file in there, and wherever it stops, that's your available length. And then you do an initial instrumentation using your Untitled Orifice Openers. Here I'm using a 2008 Esx file, coronal to that length. You don't try to reach that length. That is a safe length that has already been determined with your 1502 to be available. Now the Esx Orifice Opener is a size 20 tip with an 08 taper, and after a couple of SSC motions, and if you don't know what SSC is, it's a single stroking clean motion, you should look back at previous tutorials, we kind of get some coronal opening. I always follow my orifice opener with the use of ultrasonic and water, which removes the debris that's been cut efficiently. Now I'm going to use a number 10 hand file to determine the working length, and I'm using the PAL apex locator, and then I put both files in there and take expose a radiograph to confirm those lengths. It's very important to confirm your lengths from your apex locator, because as here you can see, you get the additional information that you have two files that do not join and you have two separate canals. So what I'm going to do now is instrument both of those to a size 1502 hand file, and now it's time to use the expediter. If you recall, the protocol for the Esx was to get a 1502 canal and then use the expediter with a single stroking clean. And you can see here on the paddle canal, right after the first stroke, we got all the way down to the apex using the expediter. So one or two strokes here, and we were already using the expediter to the apex. So now that we have the expediter down to the apex, based on the level of engagement, we determined that because it was minimal, we're going to use a size 45 tip to finish the apex. Being that this is a necrotic case, using a larger apical preparation is probably warranted, and it would be safe. So you can see here that I'm using that endo swipe, the brush that cleans the file after every stroke here. And you know, it's important that after about 4 or 5 strokes, then you use your ultrasonic and water to clean the debris that you've cut off. The SSC motion, the single stroking clean motion, really does a great job to act like a spoon and remove the debris that you've cut from the canal, which you then use the endo swipe brush to clean it off. But debris does accumulate a little bit, so after 4 or 5 strokes, it would be wise to then use an ultrasonic and water to very safely and efficiently remove the debris. So I'm only working on the paddle canal, and you can see I did about 4 or 5 strokes, and then I stopped, did a little bit of ultrasonic irrigation, and did again another 4 or 5 strokes, and then followed again by the ultrasonic irrigation, removing the debris that is loose. And now finishing it up, and you can see now we've pretty much reached the apex here with that 4504 in the paddle canal. Once you reach the apex, then you can do a little bit of lateral motion, but please remember that it's important not to do that before you reach the apex, because you really should be using SSC. Again, for a third time, I'm using the ultrasonic. This is the Forza V3 unit by Brasseler. Ultrasonic is very powerful and has these specific tips, which are size 15 or 20 file tips that you could put in there on the E11 and E12 tips with about a E1 setting, and you get very good removal of debris. Now I'm doing the same thing I did at a faster speed here. It's been a little bit fast forwarded on the buccal canal now, and I'm doing this fast forward because I'm sure you guys would get pretty bored watching this in real speed, but it's important to see that every stroke that's being taken in the canal, so you can really see what it takes to go from a size 15 to a size 45 and skipping all of those file sizes in between because of the booster tip that is present on the Esx file system. So once both canals have been prepared to size 45, now it's time to do our final disinfection. And using hypochlorite, I use the macro cannula, I use a negative pressure system. Here's the endovac, followed by the micro cannula. This is the small tip. Basically what I'm doing here is the vacuum tip from this micro cannula is going all the way down to the apex, and you can see that my full strength hypochlorite is reaching the apex and then coming back up through this little nozzle, through the vacuum, and through this little tubing out of the canal. This is a very good way of safely running a very high volume of disinfectant down the canal. Now I'm basically fitting my matching BC cones, biceramic cones. This is the 4504 matching cone for these canals. And I make sure that I use these locking pliers and I lock them at the reference point, and I confirm with my endo ring to make sure that they've reached the full 19 millimeter in both canals. And then I lock them there. And now I am basically placing the sealer into each canal. And this is the advanced technique. Remember, for those of you who do not have a microscope and do not see how much you're injecting, it's important to use the, just place it with a file. I'm now using a 15 hand file to push the sealer down. I'm actually being a little vigorous, as you can see here, by pushing it down. And we'll talk about it in the post-op that I've created a little bit of a puff on the paddle canal as a result of this vigorous action. So probably best to use the master file to gently, in a counterclockwise direction, push the sealer so that it coats the canal walls. Then I'm slowly seating the paddle gutta percha cone, master cone, followed by the buccal, making sure that they're fully seated to the full working length. It's important to have cones that are just slightly loose. You don't want to have too tight of a fit and a tug back that is too aggressive. Don't forget, the seal is actually here created by the filler, which is here the bioceramic, and not by your gutta percha, so that a very tight tuck back is not necessary. After, as you saw, I used the EndoPro 270 to remove the handles, and all I did then at that point is use a number 10 plugger to condense these down right at the level of the orifice, and now I'm using that same E11 tip with the size 15 U file to just remove the debris from the canal. I'm trying not to touch the gutta percha. After the debris, after the sealer is removed, leftover sealer is removed from the chamber, now I'm using a size 10 and 9 shoulder pluggers to just make sure that I go around the cavus surface margin of the gutta percha and I push it against the walls. And here's the final fill. You can see that there is adequate apical preparation filled in both canals. Now, because of the mesial angle, you can see that the paddle canal is actually a medium-sized puff of the bioceramic sealer out of the canal. And to many people, that is a big concern. However, don't forget that the bioceramic filler that you're using here is actually a bone cement. So in terms of its biocompatibility, there's absolutely no problem with the material getting extruded out of the end of the root. Now, we don't really want it out there. In this case, I probably would have preferred to see a much smaller puff to confirm that there is patency there. But the fact that there is a large puff is not a problem. I did call the patient, in fact, the following day to check on the patient. The patient actually had no pain at all following following this obturation. Now, there's a whole interesting conversation to have regarding creating puffs and having post-op discomfort. It's important to realize that just because you see something on the radiograph, it doesn't necessarily mean that it is in fact a cause of the symptoms. When patients have discomfort following creation of a puff or an overfill, it is most often not due to the material that's been extruded, but rather due to the mechanisms that led to the over-extrusion of the material. And what are those mechanisms? Well, clearly it is due to over-instrumentation, blowing out the apex, and pushing irrigant out the end of the root. When you use positive pressure, there's a higher chance that when you have a patent canal, then you're going to push irrigant out. And as we know, the irrigants that we use are fairly inflammatory. However, those parts do not show on the X-ray. All you see on the X-ray is a radio-opaque filler, and you would necessarily assume that if there is discomfort, that is associated with the material being extruded. So in this case, because of the fact that they use negative pressure for irrigation, and ultrasonics form the main part of debris removal in the early part of the instrumentation. And because I use SSC, I really do not push any debris out the end of the root or irrigant out the end of the root during these instrumentations. So the little tiny puff you see due to the hydraulics created on its own does not create any discomfort at all, because as you know, the bioceramic sealer material, if you put a large amount of it underneath the rabbit skin, you will actually see very little inflammation because of the fact that it is very biocompatible. So this case shows the versatility of the bioceramic sealer, as well as the efficiency of using the Esx instrumentation system, where you basically did these two canals in a very short amount of time, as you saw here, going from a number 1502 hand file to a 1505 expediter file, which we use in the SSC motion, single stroke and clean, and then we went from a 15 all the way to a 45 due to the fact that we have the booster tip in combination with the use of SSC when we fit it, this case, to a very respectable apical preparation size with only 2 files and in a very safe way. The key here is using the SSC, and that's basically it. And we have also a 3-month recall on this patient. As you can see, the X-ray is showing very nice healing taking place. It's obviously not completed because it's only been 3 months, but the patient's on its way to heal. And as I mentioned, I did again follow up with the patient in terms of any discomfort that they had, and they really had no discomfort at all because of the tiny puff of the bioceramic sealer. So this case demonstrates the efficiency that you can expect from the basic Esx instrumentation and obturation system using the bonded obturation that is now transforming really our field to be much more efficient, as well as creating effective results. For Real World Endo, I'm Ali Nasseh, and I hope you found this case-based learning tutorial helpful.